Hi, my name is Dr. Ginsberg. I'm a radiologist and I'm Director of Cardiothoracic Imaging and Vice Chair of Education at Memorial Sloan Kettering Cancer Center in New York City. Patients should be part of a screening program because cancer survivorship is a growing public health issue. We know that persons with cancer are now surviving longer than in the past. And with this length and increased survivorship, we see a risk of a second primary lung cancer. In fact, the National Comprehensive Cancer Network, also abbreviated as NCCN, has guidelines which they've expanded to now include a second high-risk group for whom lung cancer screening is recommended. And this group now includes those that have an additional lung cancer risk factor, which includes history of a smoking-related cancer. For example, that would be a head and neck cancer, family history of lung cancer in a first-degree relative, or chronic lung disease, including emphysema and fibrosis, or known exposure to pulmonary carcinogens. And that's a big change because previously, lung cancer screening programs have excluded patients that had cancer. And there was this really inconsistent approach to the inclusion of individuals with a previous history of malignancy. Some of them completely excluded them, and others placed some limitations. For example, the NLST, which is the National Lung Screening Trial, which was a large randomized trial in the United States, excluded these patients if they had treatment for or evidence of any cancer other than non-melanomatous skin cancer or carcinoma in situ, with the exception of transitional carcinoma in situ or bladder carcinoma in situ in 5 years prior to being eligible for screening. They also excluded those with a history of lung cancer. So as you see, studies have excluded these patients, so we don't have data from randomized controlled studies that it would include these individuals to actually demonstrate that there is a survival benefit. Now, we've looked at our own data at our institution, and what we reported is that in those patients that had a history of cancer, the rate of screening detected second primary lung cancer was higher than that reportedly seen in historical prospective screening studies. And our rate was higher compared, for example, it was 6.4% overall, which is quite high. Now, this is not a randomized control study, and our study would suggest that there's a need to do prospective research to evaluate the mortality benefit that screening may have in this population. But this brings us to the question, what percentage of patients are enrolled in a screening program in our institution? And unfortunately, that is low because it is not as popular screening for lung cancer as it is for other programs like breast or colon. And in the community, that's also even probably lower. It's for some reason, lung cancer screening has not taken off. And some have suggested that maybe it's, different populations have different, interest in being screened. So breast cancer screening has a more motivated group than lung cancer screening. And it could be associated with the stigma that's associated with lung cancer. Since it's a high association with screening, there is a stigma that lung cancer occurs mostly in smokers, and that unfortunately may make those individuals not feel as comfortable entering a screening program. Also, screening for lung cancer should go hand in hand with a smoking cessation program, and perhaps these individuals are still smoking and are not interested in a smoking cessation program and don't want to participate in a screening program that associates it with smoking cessation.